Bombay has become so hot. It's crazy.
Mm.
I mean, same everywhere actually. Here also.
Yes, Rohit.
Yes, sir. We are live now. Good to go, sir.
Thank you, Rohit. A very good evening to all the doctors, all the participants. Intas Women Health welcomes you all to this second masterclass of Ash Blue series. We had a wonderful and a grand successful first masterclass a week back, and now we are all prepared for the second mega masterclass on female orgasmic disorder. I welcome all the participants. I welcome all the faculties and chief guests to this forum. And rest assured, this is going to be a knowledge fest for everyone. We have two very experienced moderators today, Dr. Neeraj Jadhav, the chairperson of Foxy Sexual Medicine Committee, and Dr. Apurva accompanying him. These two will be moderating the session. Intras is very much privileged to be associated with Foxy Sexual Medicine Committee. This is a wonderful initiative from Foxy Sexual Medicine Committee. So thank you for choosing Intras as their partner. And now, without taking much time, I would hand over this forum to moderator of today's session, Dr. Neeraj. Over to you, sir.
Thank you, Lai. Good evening and welcome to Masterclass Session 2 on Female Orgasmic Disorder, brought to you by Sexual Medicine Committee Foxy in association with Intas Pharma. We are thankful to our Foxy President, Dr. Alpesh Gandhi sir, my Vice President in charge, Dr. Ragini Agrawal, and our Secretary General Foxy, Dr. Jaideep Tang, for all the support and guidance. We are glad that you liked our first session on HSDD, which was attended by more than 1,500 delegates. I am sure this second session will also be up to your expectations. Friends, female orgasm is very complex to understand. For different individuals, it's different experience. So when it is not easy to describe orgasm, you can understand how difficult to understand and manage orgasmic disorder will be. There are quite a few women who have never experienced orgasm, and women are considered passive partner in sex. So it's quite natural that orgasmic disorder are many times neglected. But with changing trends, more women are coming forward to seek treatment for this orgasmic disorder. So let's learn from our experts today about the complex but important topic. To grace today's session, we have very prominent personality with us as a chief guest. Dr. Nandita Palsatkar, a dynamic lady, past president of Foxy and present AMOX president. So many achievements are there to her credit. So I welcome you, ma'am, and please give us your blessings. Nandita, madam.
Thank you, Dr. Neeraj. I think, first of all, congratulations on selecting this wonderful faculty which is there. I think Dr. Vijay Sarthi from Australia, welcome. I mean, coming here at 10:30 in the night and talking to us, it's amazing. And of course, my friends, Sunil Jindal, Apurva, and Padmini. I mean, it's really nice seeing you after the Bangalore AICOG where I was installed to see the Bangalore people here. It's really nice. Neeraj, I must congratulate you because you know what? As you said, the trends are changing. We as gynecologists are getting patients who come and ask us a lot of questions. And then, you know, we've never paid attention to sexual dysfunction in college when we are studying, when you're doing our MD, and we really don't know too much about it, or we've read it just for exams and forgotten all about it. And then when the patient asks us, we are actually at a loss. And today's generation, or even women in my age group, I think we are women of the world. We want to enjoy everything, and the quality of life is really important. So I think you have touched on a very sensitive subject, a very neglected subject, and it's really important that our gynecologists are, educated about what can be done for the women and how they can be helped. And I think it's very empowering to a girl, empowering to a woman, because it is, I don't know, I mean, I may be veering off track, but I think it's a very important aspect of a woman's life orgasm is something I think she should not ever miss in her entire life. I know as a head of an organization, this is something I don't know whether it's correct of me to say this or not, but as a woman, I'm telling you, I think it's one of the pleasures in life which should not be denied to any woman. So if there are problems with that, I think we as a doctor should be able to help them. And when Foxy actually formed the sexual medicine committee, I think it was a lot of demand from all the Foxians, because we saw this demand in our patient group, and that is how it has come forward. And you have, the previous chairpersons have done fantastic work and got it to this level of awareness. And I think I must congratulate you on the work that you're doing. Fabulous work. You've really taken it upon your shoulders to spread this awareness. And I'm so happy that you're doing it. In fact, today, I am preparing a lecture on precision medicine in reproductive medicine. And I was reading all this hi-fi genetics and genomics and proteomics and all that. And I said, oh my God, here I'm thinking about this. And I am going for a program which is something basic, which is a requirement in a woman's life. So these two opposite ends, but both of them are required. So I think in today's world, we need to touch this end as well as that end. And I'm glad we have people who are, doing both the ends. So congratulations, Neeraj, and all the faculty. I mean, I'm sure you'll have a fantastic deliberation and all the questions which are there in the box. It's exciting how much interest and how much, lack of knowledge also there is. So I'm sure your program will be a success. So all the best. And Neeraj, keep the academics going and let us educate everybody. Thank you. Thank you very much. And I'm happy. Thank you for inviting me here.
Thank you, madam, for your blessings and taking time out of your busy schedules. We are very much thankful for your presence. So now I invite my co-moderator and our National Public Awareness in charge of the Sexual Medicine Committee, Dr. Apurva Datta, to introduce and welcome our three masters of today's sessions. Over to you, Apurva.
Thank you so much, sir. Thank you, Nandita ma'am, for sparing your precious time and blessing us with your kind words. So without wasting the time, let us start our scientific session. We have three eminent and dynamic faculties with us. The first is none other than Dr. Padmini Prasad ma'am. Ma'am is currently President, Bangalore OBG Society. She is also the National Coordinator for Foxy Sexual Medicine Committee. Dr. Sunil Jindal sir. Sir is Chief Consultant, Laparoscopic Surgeon, Andrologist, and Reproductive Medicine Specialist of Jindal Hospital. Dr. Vijay sir. Vijay sir is Lecturer in Sexual Health in Westmed Clinic School, Australia. Welcome to all of you, and we have to start our session. Okay. Now, for the first question to you, Vijay sir, what is actually orgasm is? We all are talking about the orgasm a lot, orgasm. What actually is meaning, and in a simple word, what you can define so that our audience can know what orgasm is actually. Over to you, sir.
Right. All right. Thank you, Dr. Datta, and I'd like to thank Dr. Jadhav for inviting me. I think for the greater cause, I didn't mind the time, so it's a pleasure for me to be here. Now, can I share the screen now?
Yes, sir. Sure, sure.
Okay, can you see the screen?
Yes, sir.
Yep.
Absolutely.
All right, 1 second. All right, as Dr. Nandita said about precision medicine, I wish my topic was similar to that, whereas anything to do with orgasm is no precision there. So let's get on to what's orgasm, and I'll take 10 minutes and I will put my timer so that I'll finish it on time. So I will declare no conflict of interest in doing this presentation. So those are my affiliations, and you can get my contact details later. But before getting into orgasm, let me start with Dr. Nandita Palshek has said, pleasure. Orgasm is very much to do with pleasure. And pleasure is something we medical doctors don't tend to think it's scientific. If somebody start talking about pleasure, oh my God, that's not my area. I'm not here to deal with pleasure. I'm here to deal with problems. But pleasure is such an integral part of who we are. And that's why sexual pleasure is one of the rights declared. And also the World Association for Sexuality has got a statement on sexual pleasure. So it's a very important area, Dr. Palshekar, that you said. And pleasure forms one of three pillars of happiness, along with engagement and meaningful. Pleasure forms a very important part of happiness as well. So going on from there, when we talk about orgasm and orgasmic disorder, not everyone has got a disorder. Some might have difficulty and some might just have concerns. So not everyone who has a concern has got an orgasmic disorder. So this is very important to understand the 4 different types of sexual problems. Let me come to orgasm in a second. I haven't forgotten my question, but I want to, I'm getting a lot of interruptions. Sorry, I think somebody has to put their mic on mute. All right. So with difficulty and disorder, the prevalence is going to be addressed by Dr. Padmini Prasad. But all I would like to say is, if you look at the number of women presenting with orgasmic difficulty, it's twice the number of women who present with orgasmic difficulty and distress, which captures the definition as per DSM-5. So the point is, there are more women with orgasmic difficulty, but only half of them get the distress and being diagnosed. Now, before going on to orgasm, it's important to understand the organ, specifically clitoris. Now, most of us, gynecologists excluded, but all others tend to think clitoris is a tiny weeny organ just at the tip of the, near the vulva. But it's just the glands, but clitoris is a much bigger structure. It's a butterfly structure. And the bulb of clitoris is almost 10 times the size of the glands. But that's not how the public understand. And there's always this saga between clitoral versus vaginal orgasm. If you read a lot of literature, especially the early literature, there is a saying, there's a lot of emphasis that vaginal orgasm is far superior, far pleasurable, and far healthier than the clitoral orgasm. But that has been busted because the vaginal orgasm does involve the clitoral complex. So there is no question about which one is superior than the other. And there is no evidence to support that vaginal orgasm is superior to clitoral orgasm. Now, this is a very interesting slide, and this is the sexual response model that is being used in DSM-5 heavily, and this has superseded all other models. But if you look into this Besson's female sexual response model, there is not a single word of orgasm. Okay, so the one that I put as a cloud, I have introduced that for today's session. But if you look at the actual model, there is no mentioning about orgasm. Now, why is that? We will address it later, but it's important to understand that orgasm is not always equal to the sense of pleasure. So some women do experience sexual pleasure even without actually experiencing anything very objective about orgasm. So we'll talk about that a bit later. But in general, in men, orgasm has got a very objective element of ejaculation, even though ejaculation and orgasm are not same process. They are two separate processes, but it happens very closely, but there is something very objective. Whereas in women, there is no such objective measure. So it's very subjective, okay? Finally, so what is this thing called orgasm, okay? So this is a definition of peaking of sexual pleasure. Now that's the word Dr. Palshekar did, Dr. Nandita said, it's the peaking of sexual pleasure. So it's the nth, it's the peak of sexual pleasure with release of sexual tension and rhythmic contraction of the perineal muscles. So this is, once again, this is not a set definition, and everyone who has tried to define orgasm has failed in the attempt. So there is no one uniform definition. And that is a problem in itself, like Dr. Jadhav said before. So in female, orgasm is accompanied by contractions, okay, of the outer 1/3 of the vagina, which is very much the pelvic floor. Whereas in both gender, there is anal sphincter contraction. But the orgasm, as a working definition, is a peaking of sexual pleasure and release of tension. So that's what orgasm is all about. But it is not as simple as it is. So if you look into this slide here, pelvic muscular contraction, it's a voluntary contraction, but what is the function of it in terms of orgasm? Now, the question we need to ask is, does any contraction produces pleasure? So pelvic muscle is a very thick muscle. So contracting pelvic muscle, does it really give a sense of pleasure or a pain? So that's a question we need to ask. And what is the function of it? Now, the other physiological symptoms we can understand: peak in respiration, heartbeat, blood pressure, pleasurable feeling of release, we can relate to it. Contraction of the uterus. Now, no woman is going to experience or feel the contraction of the uterus, but it is happening. Now, the tenting effect, there is some relevance in terms of reproduction. Okay, when the tenting effect happens, there could be a possibility for better sperm transport. But in terms of pleasure, it has got nothing to do with it. Now, multiple orgasm, once again, this is a question asked by somebody. So multiple orgasm is possible. And it is not to say that only women can experience, men can also experience multiple orgasm. And there is no one phenomenon that explains why some women experience multiple orgasm. Now, within multiple orgasm, we need to understand the two different subtypes. One is the repeated, the other one is sequential. The repeated is where you get orgasm and then nothing, even though the sexual arousal is still up, there is nothing happening, and then you get another episode of orgasm, maybe 2 or 3 within a gap of 20, 30 seconds or max 1 minute. But sequential orgasm is different to repeated orgasm. Sequential is you get a low intensity and then it gradually increases to a full final orgasm. So it's more of a graded intensity. So there are two different subtypes of multiple orgasm. Now, the most important thing in terms of the clitoris and the G spot and the A spot and B spot, there's so much media attention on all these spots, but technically what it is the anterior vaginal wall complex. So that's the term we use. There are a lot of the clitoris pressure along the anterior vaginal wall is everything to do with orgasm in women. So that's something you need to make a note of, and we'll come to that when we talk about management. Now, couple of quick snapshot information. There's been a lot of controversy when it comes to orgasm, especially in terms of what is the function of orgasm. Has it got an evolutionary purpose? What is the actual purpose and function of orgasm? It is not clearly defined, and there is no clear-cut answer to that. Now, and how does it induced? Still, it is not very clear. Okay, there is a central level, there's a spinal level. We're talking about inhibitory hormones, we're talking about excitatory hormones. There's a lot to discuss about that. Now, orgasm is not linked to, orgasm is not linked to subjective feelings of pleasure. Okay, so somebody might not have orgasm, but still they might have a subjective feeling of pleasure. Okay, because there is no objectivity here, it's very hard to say whether the person has got an orgasm or not. Now, does orgasm relate to reproductive fitness in a woman? No. The answer is no. Does orgasm facilitates better sperm transport? Absolutely not. So that's a reference there, and it has clearly shown that orgasm has got nothing to do with better sperm transport. Now, we already discussed orgasm by vaginal stimulation is healthier than clitoral stimulation. Once again, the answer is no. It is not superior or healthier than the clitoral stimulation. Now, one thing we need to understand is pleasure versus pain. Okay, so if you look at the two pictures, which one is orgasm, which one is pain? It's not very easily distinguishable. And sometimes when a person is experiencing orgasm, we really don't know whether it is pain or whether it's orgasm. And that plays a big role in the partner's expression of their sexuality. Now, these are the issues related to defining orgasm. Because there is very limited understanding of the mechanism underlying orgasm, and because there is a lot of reliance on subjective or self-report of orgasm, there is no universally accepted definition of orgasm, which then leads on to the difficulty in defining female orgasmic disorder, which is what Dr. Padmini Prasad is going to talk. Now, in summary, orgasm is highly subjective. There is no objective marker as in males like ejaculation, but please do know orgasm and ejaculation are not the same. They occur very closely in men, but they are two separate processes. Experienced in very different ways. Even the same individual doesn't experience orgasm the same way at every single occasion. So there is a lot of variability within the individual and between individuals. There are various descriptions of orgasm. Okay, some people they say that I don't remember anything what happened during the orgasm. So that's altered consciousness. So there's a lot of descriptors of orgasms. And there's also evidence to show there are a lot more similarities as well as differences in orgasm between men and women. And now there is a lot more convincing evidence that many women require clitoral stimulation to reach orgasm. So technically speaking, just relying on penetration and expecting women to experience orgasm, it is a big ask, provided it is still possible, but it takes a lot of effort, and there are a lot of ifs and buts need to be addressed. Okay, because remember that clitoral stimulation forms a major part of the orgasm, and clitoral stimulation is not necessarily by stimulating, it is mainly by pressure. So the pressure plays a big role. So that's why a thicker penis in a heterosexual context, a thicker penis in certain position can actually increase the chances of having a clitoral orgasm or a vaginal orgasm. But we'll talk about that more in the treatment aspect. Yeah. So that's it. I would like to finish it there and
Thank you.
pass on to the next speaker.
Thank you, Dr. Vijay, for explaining superbly about what is orgasm, because it's very difficult to make it explain in simple words, but you have done beautifully explained about it. So now I invite our next master, Dr. Padmini Prasad. She will explain us about what is female orgasmic disorder, what's background, what is pathophysiology involved with it, what's etiology, and what epidemiology of the female orgasmic disorder. So may I request Dr. Padmini Prasad to tell us about these issues.
Thank you very much, Dr. Neeraj. I really thank you all for giving me this wonderful opportunity to discuss on this subject. Can you see the slides?
Yes, yes, we can.
Yeah. Thank you very much for this opportunity to be with so many stalwarts in this field. And coming to this female orgasm. See, if you say sexuality has evolved into what it is today through many researchers, discoveries, experiments, and writings of many activists by changing the view of what is considered normal or morally right. Women in general have accepted sex as a necessary but pleasurable part of life. They are convinced that they have an equal right to partake in pleasures of sex as do men. This may not be true with all women because of it depends on their education and knowledge level and the expectation and their personal experience. I thank Dr. Vijay for explaining so many things about the orgasm, which are the real truth. I will go through certain things and how people talk about various ways of orgasm. And here you can see the best quote. Women can have multiple orgasms, men cannot. They are actually the sexual athletes, not the men. So there are various searches for female orgasm if you go to social media compared to all the other things. And sexual response depends on a complex interplay of physical, psychological, and emotional factors between two persons. It is coordinated by the neurologic, vascular, endocrine systems and influenced by family, society, and religious beliefs. So many things can act on this sexual relationship and the sexual response. Any disturbance in any of these factors can disturb the actual pleasurable component of sex. So traditionally, if you see that human sexual response cycle of Masterson, Johnson, and Kaplan, having the desire, arousal, plateau, and orgasm, and the Basson's cycle also, which Dr. Vijay showed, how the orgasm is not mentioned, but the pleasure component is mentioned. Now there are various talks about enhanced orgasm, expanded orgasm pattern in expanded sexual response cycle, ESR and EVO, as defined in various resources recently. These are the things which are being discussed and various on the recent studies. You can see this, though, then of course, in reality, there is a one orgasm, that is coital orgasm, with the ramifications of the erectile tissue all around the vagina, in the vulva, around this genital complex. So, but still, there are various nerve pathways which are described. 4 nerve, 6 pathway theory of female orgasm. At least 6 pathway orgasmic reflex arch. These systems work during the development of female orgasms. Pudendal nerve, pelvic nerve, hypogastric, intercostal nerve, and vagus nerves constitute the main nerve network system. Also, there are at least 2 oxytocin pathway systems, whereas oxytocin works as a neurotransmitter and as a hormone separately. During this expanded orgasm and ESR orgasm, more studies need to be done on these things. More than one orgasm reflex, the reflex arch pathway is activated and trigger an expanded orgasm, while many others contribute to the formation of an EVO or ESR orgasm. You can see that various nerves, how they take part in the final development of the orgasm. So what is female orgasm, which so nicely explained by Dr. Vijay. Just for the flow, I have taken some slides. Female orgasm itself has been comprehensively defined as a variable, transient, quick sensation of intense pleasure, creating an altered state of consciousness, usually accompanied by involuntary rhythmic contractions of the pelvic striatal muscles, circumvaginal musculature, often with concomitant uterine and anal vaginal contractions, and myotonia that resolves the sexually induced vasocongestion, sometimes only partially, usually with an induction of well-being and contentment. So if effective sexual stimulation continues late in plateau phase, a point may be reached where the body suddenly discharges its accumulated sexual tension in a peak of sexual arousal called orgasm. It's a total body response involving the brain, spinal cord, sympathetic nervous system, peripheral nerves, muscles, CVS, and genital organs. So it is by Masters and Johnson's, it is described as a brief episode of physical release from the vasocongestive and myotonic increment developed in response to sexual stimuli. Psychologically, it is subjective perception of a peak of physical reaction. So these things are also described by Dr. Vijay. This is an intense feeling of physical pleasure at the culmination of sexual stimulation, marked by rhythmic muscular contractions of uterus, outer third of vagina, and anal sphincter. There can be mild orgasm or intense orgasm. One thing is that you cannot, like how you cannot will an erection, you cannot will this rhythmic contractions of the vagina. It is an involuntary reaction. So the different muscles contract and sex flush can happen. Women describe orgasm as beginning with a momentary sense of suspension, quickly followed by an intensely pleasurable feeling that begins at the clitoris and rapidly spreads throughout the pelvis. Genital sensations are described as warm, tingly, and these spread through the body. Finally, most women feel the muscle contractions in their vagina and lower pelvis. So this is described as pelvic throbbing. Most women do not ejaculate. I have seen so many women coming and asking, I get a lot of pain after intercourse. So what is this contraction, this pelvic throbbing, or the tenting effect and raising of the uterus and uterine contractions? That itself, some women think that that is an abnormal thing or they are having some problem. So this is the shortest phase of sexual response cycle. It is over very quickly, madam, they say. So I am not enjoying anything. I am not really happy with the sexual interaction. It only lasts for few seconds during that rhythmic contraction. Psychologically, orgasm is a time of pleasure and suspended thought. Mind turns inward and enjoys the experience. Orgasm can be mild, moderate, or absent. So this woman's orgasmic capacity depends on her age, sexual experience, sexual stimulation she receives, and her relationship with the spouse. So these are all various terminologies which are being used. Anorgasmia, as you know, if there is no orgasm, an anorgasmia, and multiple orgasm, which was also described. Woman is capable of multiple orgasm. Extended orgasm, which recent studies, some people are describing. Pre-orgasm. So they are about to reach the orgasm, but they just stop at the pre-orgasmic level. Missed orgasm. They wanted to have the orgasm, but they just missed it because of the lack of continued stimulation or some problem with the male sexual functioning. Elusive orgasm. So I have never reached this orgasm. I don't know what it is. Faking of orgasm. Because if there is a loving relationship, women think because the husband should not think bad about himself or he should not feel bad or worry. So they just fake the orgasm as though they have got the orgasm. The simultaneous orgasm, which has been described like clitoral and vaginal orgasm. These are all various terminologies which people use. So these are the different types of female orgasm which are described, and a lot of studies need to be done on this. This number one is clitoral orgasm, because by the stimulation of the clitoris, though it looks like that it is only the clitoris is stimulated, but deep inside it's a very big organ. Vaginal orgasm, we do not really know. Could be caused by stimulation of the G-spot or maybe an indirect stimulation of the clitoris. Exercise-induced orgasm, it's also known as coregasm, where during exercise, when the pelvic muscles are stimulated, they feel that orgasmic feeling. Orgasm during sleep, that also really do not know what exactly is the cause for that, whether it is because of the sexual dreams or because of some other stimulation in the sleep. So other things like stimulation of the nipples, anus, even when the woman is breastfeeding, and because of the stimulation of the nipples, she can have that orgasmic feeling. That's also seen and experienced by many women. Stimulation of the anus and other sensitive areas in the body. It may be just a mental stimulation and imagination that itself can cause orgasm for the woman. So there can be combo orgasm, which is described. It can be achieved by pleasuring the vagina and clitoris simultaneously. The result, a powerful climax that one can feel inside and out. Some of the vibrators, like rabbit vibrators, for example, which is shown in the figure, It can stimulate the clitoris and vagina at the same time and are perfect for mastering the combo orgasm. Cervical stimulation. It's also said it has the potential to lead to a full body orgasm that can send waves of tingly pleasure from head to toes. And this is an orgasm that keep on giving, lasting quite a while. The doggy style position allows for deep penetration to try being on all fours with a penetrative toy or partner. The clitoris contains a bundle of nerve endings, which was shown earlier. What you see is very little of what exactly is clitoral. The clitoris, similar to penis, will swell, enlarge, and become more sensitive as a person becomes more sexually aroused. So direct or indirect stimulation of the clitoris is the one which leads to the orgasm. Even the fingers, palm, or a small vibrator can stimulate the clitoris, but the clitoris has to be wet. Otherwise, it really causes a lot of pain or irritation to the woman. As it begins to feel good, a faster, harder pressure can be applied on the clitoris. When one feels pleasure intensified, and even more pressure to take her to the edge. Although few people are able to climax with vaginal stimulation alone, it sure can be fun trying the other things. So there are so many things described in the anterior fornix, A spot, or in the higher up, a G spot. All the stimulation of these things, probably behind that lies that erectile tissue and ramification of clitoris. Where does the G spot come in? The G spot is an area along the front wall of the vagina. For some people, it can produce a very intense and very wet orgasm. So fingers or a curved G spot vibrator can be used. So the G spot felt in the vagina an inch or two behind the back of the pubic bone, near the junction of the bladder and the urethra, and made up of tissues of the clitoris. That's what says Dr. Whipple. So the G spot, some people still think it is a retracted or enlarged clitoris. G spot doesn't exist at all. So other things, the erogenous zones in the body. The body really is a wonderland. The neck, ears, and lower back, for example, are rich in erotically charged nerve endings begging to be touched. We can't say exactly which parts of the body will drive one to the brink, but we can tell that everyone has erogenous zones, and finding them is definitely worth the effort. Nipples are full of nerve endings that can feel oh so good when played with, when stimulated. They set you the genital sensory cortex ablaze. So they say there are nearly 100 erogenous zones in the human body of wonderland. So the bottom play also can be pleasurable for someone with the massaging or the sex toy or the finger. So this is what I was describing. Exercise induced orgasm sometimes can happen. So they say that it makes sense biologically as both exercise and sex can stimulate the muscles around the genitals and can lead to increased blood flow to the area of the body, genital area of the body. So exercise may also influence the mood via these good hormones and endorphins and other neurotransmitters similar to that seen in sex and orgasm. So the orgasm during sleep, how do you explain? Many people experience sexual arousal or orgasm during sleep. It is difficult to say what or how exactly this happens because reporting from dreams can be unreliable. It is difficult to say if all arousal and orgasms during sleep are caused by sexual dreams. Similarly, there is no research whether the people were unconsciously stimulating their bodies during sleep. So is there a female ejaculation? As it was told, the ejaculation is looks like an end point of this indicates orgasm in the man, though of course there is slight difference between the two. But is there a female ejaculation? They still say that some women do experience an ejaculation, which is the fluid which comes out of urethra, and it is different from urine, and it may resemble the semen are the same components of semen minus the sperms. So is there a difference between female orgasm and a male orgasm? They aren't all that different. Both involve increased blood flow to the genitals, faster breathing and heart rate and muscle contractions. Where they typically differ is in duration and recovery, which is known as afterglow. Female orgasm may also last longer compared to the man. So men will have refractory phase where the orgasms aren't possible during this phase. It can last from your minutes to days. So then there is ejaculation. So once you understand this orgasm or the pleasure component, how it is different in different ways. So female orgasmic disorder is characterized by a persistent or recurrent distressing compromise of orgasm frequency, intensity, timing, and or pleasure associated with sexual activity for a minimum of 6 months. According to DSM-5 classification, the distress or the disorder should be lasting for 6 months or 75 to 100% of the times it is there. So this is persistent or recurrent delay in or absence of orgasm after a normal excitement phase causing marked distress or interpersonal difficulty. So sometimes the couple may not tell that there is a problem. Though there is a problem, if they think that it is normal part of their life and they are not worried, then you cannot call it as a disorder. Only if it is causing distress to either to the woman or to her partner, then we take it as a disorder. It can be a primary orgasmic disorder where it is there right from the beginning and the woman hasn't experienced any orgasm, or it can be a secondary orgasmic disorder where it was there for some time, but after that she is unable to experience orgasm. It can be situational, which is present at some point and which is not present at other situations, or it can be global at any point of time, at any circumstances, under any situation. So this female orgasmic disorder, frequency of orgasm occurs with reduced frequency or diminished frequency of orgasm, or is absent or complete anorgasmia. Intensity, orgasm occurs with reduced intensity or a muted orgasm. The timing, orgasm occurs either too late, a delayed orgasm, or too early, spontaneous or premature orgasm than desired by the woman. The pleasure component, orgasm occurs with absent or reduced pleasure. If you see the epidemiology, global study of sexual attitudes and behaviors found that women aged 40 to 80 years, inability to achieve orgasm varies across various regions with frequencies ranging from 10% in Northern Europe to they have very high percentage in other areas. So you can also see that the dysfunction rates vary from 16 to 25% in Australia, Sweden, United States, Canada to 37% in Iran, and 72% in Ghana. So this is the prevalence of FSD. If you take the different phases of the sexual response cycle, desire, arousal, lubrication, orgasm, satisfaction, and pain. So if you consider that, you can see that almost all of them are equal and the orgasm constitutes about 70% of the cases. So 5 to 10% of cases are anorgasmic by any means. They are unable to reach orgasm by any method of stimulation or any partner. 90% of the women are orgasmic by some means or the other. 50% of women usually climax during the coitus. So the risk factors, I only just in a broader way I tell because the next speaker is going to tell about all these things. The temperamental factors, the psychological component, environmental factors, any illness, disease, surgery, medication, or there can be organic or non-organic causes can contribute to orgasmic disorder. Anything that leads to low desire or anything that leads to arousal problems can also, or dyspareunia can lead to orgasmic disorder. And the male problems, inability to stimulate the partner or take her to the edge, or it can be an erectile dysfunction and premature ejaculation. And the sexual abuse, the woman who has gone through sexual abuse or child sex abuse may be unable to reach orgasm because of some negative attitude, or ignorance, false expectation are also the causes. So when you come to this prognosis, little is known about the natural course of FOD or about the prognosis for women with untreated FOD. Some cases of the acquired and situational times seem likely to resolve spontaneously. Patients with lifelong and generalized types of FOD appear to have a good prognosis with treatment, but an uncertain prognosis without treatment. So the medical history is very important. Any chronic medical conditions and cardiac, pelvic, neurological conditions, whether the anxiety, depression and other problems, and the laboratory workup, all these things will be told to you in detail by our next master. So these are some of the basics. So the treatment approach depends on the causes and psychotherapy, pharmacotherapy. Women are encouraged to take responsibility for their own sexual pleasure during foreplay, coitus, and afterplay. Suitable environment, relaxed atmosphere are very important for the woman. So these are all various management issues. I will not go into the detail. So a happy sex life. Although portrayals of orgasm in media, partners' expectations for our orgasms, and our own interest in experience orgasm can make us feel like we need to have an orgasm every time we have sex. A happy sex life doesn't necessarily mean having a mind-blowing orgasm during every sexual experience. Orgasm is just one of many important elements to sexual satisfaction. Many people report that not all orgasms are the same, which makes sense. Our minds and bodies change from day to day due to mood, health, stress levels, etc. It is unrealistic to expect any type of stimulation to elicit the same experience every time. So orgasms are also difficult to study. Similar to studying mood or pain, female orgasms need to be interpreted through not just biological mechanisms, but also psychological, sociological, and historical trends. Historically, in Western countries, female orgasms have been highly scrutinized. Orgasms were sometimes seen as unhealthy or wrong, and orgasms that are achieved through stimulation that is not heterosexual vaginal intercourse have been considered unacceptable by researchers and doctors earlier. So Sigmund Freud popularized the idea that mature women experience vaginal orgasm while immature women enjoyed clitoral stimulation. Many people feel that orgasm is a requirement for happy, meaningful, and or fulfilling sex. Some people also feel that orgasm should be reserved for sex as opposed to experience orgasm during masturbation. Orgasm is great, but feeling pressure to have an orgasm or a certain type of orgasm at a certain time can make sex stressful and unpleasant. Intimacy, sexual pleasure, sexual satisfaction do not depend on orgasm always. So this is the algorithm for the management of female anorgasmia, which will be told to you by the next speaker. So I will not go into the detail. So this is what is orgasm, what you should know about it, how people talk about it, and how it can cause stress to the woman if she is experiencing or expecting an orgasm. So many women may be happy or they may be experiencing orgasm, but they do not know because of now with the media projection and the literature available in and the pornographic sites and blue films and all these things. So the women are having unrealistic expectations these days, and that is causing more pressure on the man, which is really causing disturbance in the relationship. Thank you very much for the wonderful opportunity.
Thank you so much, Padmini ma'am, to make such a difficult topic in such a simplified and in such a simple word. Thank you so much. So moving to the next part of our session, that is our next question to Sunil sir. Sir, just wanted to know from you what actually, when the patient is having this female orgasm disorder, what is actually basically presentation? But what different type of complaints he present to the OPT? The first thing. Secondly, how actually we differentiate these from the other disorders, and what to work up and how to evaluate this type of patient. Over to you, Sunil sir.
Thank you very much. Thank you very much for this amazing program which has been set by you. And Dr. Padmini, you have been amazing, in fact, as always. Dr. Vijay Sarthi, it's such a pleasure to always listen to you. And you have made my job so easy, both of you, by having these fantastic lectures before me. Well, Presentation, first of all, is not there because in our country, a lot of women do not want to talk about it. A lot of women actually feel that this is not a part of the whole repertoire. In fact, they feel that the most important thing is for the husband to be satisfied, and the husband is satisfied and the intercourse is over. A lot of women can't even ask their husbands that this is where I feel nice. Can you stimulate me? And the result is that orgasm is something which is very little spoken about. But a few patients, the way they would present, I would just name a few patients and talk about them, the way they would be. 27-year-old lady, married for 4 years, greatly in love with her husband. Husband always has an orgasm, has a premature ejaculation, leaves after that. And though the relationship, as far as love is concerned, for her husband is great, but not an orgasm. And a friend of hers tells her that, well, orgasms are amazing. And then she comes to know that there is something to be experienced. And then she comes to talk about the orgasm. A woman, 37-year-old, married, but in a relationship with somebody else, now does not get any orgasms with her husband, but has orgasms with her partner. And the situation and the presentation is so different. But the truth is, it is such a complex matter where in female sexual dysfunction, the hypoactive sexual disorder, orgasmic disorder, pain disorder, psychology, childhood, relationship, the sexual relationship and the sexual status of the partner, they all get together to bring about a complex structure. So it's a very, very enigmatic and interesting thing to understand. So I'll just start my mind note because I wanted to bring out a few things very pertinent for all of us to understand. And let me just open my mind note. So I'm going to talk about the strategy, the factors, the health problems which can lead to an orgasmic disorder, the way the history would be presented, a few things about the physical examination, what is the differential diagnosis, how will you work up, and the algorithm. Though everything has been made very simple by Dr. Vijay and Dr. Padmini, and Dr. Vijay is going to, after this, of course, come up with the treatment. So I'd like to be brief in a few things and like to expand on a few things. So first of all, the strategy of asking a patient of how now it's a very interesting thing. You just can't go to a patient who's come to you and ask, do you have orgasms or you don't have orgasms? You really have to bring the patient to an area where these closed-ended specific questions could be asked. So explaining, sitting down and talking to the patient, then gradually going on to sexual issues, having open-ended questions, which means questions which could answer anywhere, which not directly would be about the sexual relationship or more than that, the sexual process, and then coming up to closed-ended specific questions would be the strategy, which Dr. Vijay would be talking to you about. Now, I'd like to talk about a few factors. Whenever you take the history of a patient with any sexual disorder, you need to know about, has the patient had any kind of sexual abuse or rape? This history will actually change the way a woman has her deepest behavior towards sex. Asking a patient after some time whether there is boredom in the relationship or sex, whether there is fatigue, stress, depression. A lot of people have lack of knowledge. There are a lot of women who have never known anything like orgasm exists. In fact, you'll be surprised to know that a very large chunk of women, about 30 to 40% of Indian women, do not even know that something like orgasm exists or that is something for them to enjoy. Negative feelings towards sex, negative feelings towards partners, negative feelings towards, per se, the whole structure of sexual pleasure can also be a question which needs to be indirectly asked. In our country, you'll be surprised. Just like male sexual dysfunction when the man does not consummate marriage because he does not know how to have sex. Similarly, a lot of women till quite long remain shy in their life to ask their partner for excitement or tell the partner, this is what I like. And in fact, their fear stems out from an area where they're asking their partner may feel, I would say, not appropriate or vulgar. And there, of course, a lot of partner issues, which a lot of women may be having. Now, these histories need to be known by us, and these are factors which affect. Now, what are the health problems? Drugs. Contrary to the idea that cocaine, marijuana lead to great sexual pleasures, they lead to hypoactive sexual disorders as well as orgasm issues. Hormonal problems. Whenever estrogen is low, whenever testosterone is low, it not only leads to hypoactive sexual disorder, it also leads to orgasmic disorders, menopause, with dryness of vagina, low estrogens. It leads to less orgasms. Chronic illnesses like arthritis, pelvic pain, endometriosis, damage to nerves, spasms, and dryness of vagina. These are issues which need to be asked about, which you need to know about. But these are things which are normally as a questionnaire. A lot of questions come out in the questionnaires itself when given to these patients. Next, we come to the history. Now, the woman needs to be asked a few things in history, and these are interesting because what she actually needs to be asked is if there is any physiological issue like neurological, cardiovascular, cancer, urogenital disorders, medications as depressive for OCPs, and even if OC pills are given for that matter, it leads to a situation where a lot of women become hypoactive sexually and orgasmic disorders may be there. Endocrine disorders. Psychologically, she's depressed, stressed, past sexual problem, alcohol, substance abuse, interpersonal relationship with the partners. A lot of places there is no privacy. There is a house where so many people are that they look for a time to have intercourse. At times it becomes very difficult to get orgasms in this. And of course, socio-cultural influences. When you go towards Africa, Ghana, just like the slide which Dr. Padmini showed, 76% women have problems with orgasms. Our country has up to 44 to 50%, and it is less in the Western world. So socioculturally, it becomes a big thing of why this problem exists. Now, what would you do in the physical examination? You'll do a general physical examination, cardiac, pelvic, neurological examination, and just check if this person is mentally anxious. Now, something which we need to also look into is a differential diagnosis. And by definition, which Dr. Vijay as well as Dr. Padmini had said, the definition criteria would only be met if there is no hormonal disorder, no chronic disease, there is no depression or anxiety disorder, narcotics are not taken, antidepressants are not taken, anxiolytics are not taken, alcohol is not taken, and there is no other medical condition. Now, what are the laboratory tests which we need to do? So we need to do a CBC. We need to do a vaginal pH and smear to rule out any infection, any dryness, any changes in the pH. Need to do chemistry for the renal functions, liver, any inflammatory disease. Thyroid is another important investigation to be done. A lot of women in the perimenopausal or menopausal time, we need to do an FSH, LH, and E2. Prolactin is not only a reason because of which women have hypoactive sexual disorder. Prolactin also needs to be done if there is an orgasmic disorder. A low testosterone in women is another thing which leads to hypoactive and orgasmic disorder. So testosterone needs to be measured, and in the previous lecture which we had and the masterclass which we had, we spoke in detail about how to give testosterone if it needs to be given. And of course, a lipid and urine analysis is important. Now, as far as a rating scale is concerned, if you look at it, the female sexual function index scoring is a beautiful way for us to know exactly what the problem lies. We could know what is the desire of interest, what is the level of desire, how often is the woman aroused, and what is the level of the sexual arousal. Is she confident of being aroused and having an orgasm? And how often is she satisfied after that? Satisfaction over here at times may be or may not be an orgasm. Further on, lubrication. How good is the lubrication? How difficult was it to get lubricated? How difficult or good it was to maintain lubrication? How difficult it was to maintain lubrication until the completion of the activity. And also asking her of how many times and how often does she orgasm? And how difficult was it to reach orgasm? Does she feel satisfied? How satisfied has she been with the amount of emotional closeness during sexual activity? How satisfied has she been about her own and whole sexual life? And how often did she experience discomfort? What is the level of discomfort? Now, all these questions together give us a complete scoring, and they also let us know. They also let us know of where exactly the historical or the history of the problem is. So at times giving a questionnaire is much more easy than asking these questions. In fact, asking all these questions is not possible. Having a questionnaire is brilliant. So this questionnaire needs to be filled. And of course, the algorithm which is there about us knowing whether it's a medical condition. Is the medical condition because of a natural or surgical menopause? Is it because of an endocrine disease, drugs, neuropathies? Is there unawareness of genital anatomy, a poor sexual repertoire, poor concentration? Are there any sexual psychological conditions, repression, interpersonal relation difficulties, sexual assault, abuse, or others? We need to know all these things because the treatment, as would be covered by Dr. Vijay, would be based on these things. And that's what is so important for us to take a history about. And if you ask me, probably something very different, probably by changing partners or practicing masturbation would not be the most interesting thing for a woman to go through orgasms. More important, which is there, is the key to more frequent orgasms lies in the mental and relationship factors. These factors and capacities include orgasm importance, sexual desire, sexual self-esteem, openness to sexual communication with your partner. In fact, most of the women value their orgasm less than their partners. Do we know something very interesting? That it takes about 3 to 5 minutes for a man to orgasm during masturbation. And it also takes 3 to 5 minutes normally for a woman to orgasm during masturbation. It is about the same time. However, the number of women who get an orgasm is much less compared to the men, because men, for them, it is the end of the story. But for women, at times, it is the beginning of the story. And let us also understand another thing, that positive determinants are the ability of the woman to concentrate, mutual sexual initiations, and good partner relationships. In fact, all these things together can lead to what I would personally feel good orgasms and a complete sexual, sorry, and complete sexual happiness. In fact, I can never forget एक बड़ा खूबसूरत शेर है राहत इंदौरी साहब का। यहाँ पर बहुत बढ़िया चलता है, इसलिए आपको सुनाऊंगा इनमें कि फैसला जो भी हो, फैसला जो भी हो मंजूर होना चाहिए, और जंग हो या इश्क हो भरपूर होना चाहिए। तो सच कहूं तो ऑर्गेजम्स होने जरूरी हैं, आदमी को भी और स्त्री को भी। एंड फीमेल ऑर्गेजम्स आर not there in about 40% of women, which is much more than the number of people infected by corona at the moment in this great country, and probably one of the largest populations and diseases ever present. So thank you very much, all of you, for being here, listening to us. And let me be honest, thank you so much for your time. We are privileged. In fact, I feel honored that you are here to listen to what I really wanted to tell you and what I feel about. Thank you very much.
Thank you, Dr. Sunil, for beautifully explaining how to approach and diagnose and how to evaluate such type of patient when patient come to your chamber. So now we have known, we know that how to diagnose female orgasmic disorder. So we would like to know about the how to manage such type of patient. And for that, I invite Dr. Vijay to enlighten us about the management part of the female orgasmic disorder. So over to you, Dr. Vijay. Can you?
Yes. Can you see my slide?
Yes, yes.
Yeah. All right. Look, I think it's great to listen, and there will be some overlap, which I think it's good. It's all the key points are getting reinforced, which I'm very glad. And few things I would like to mention up front is, this is what I'm working in Australia with Sydney University with my student projects, that if you look at most of the literature, we are still talking about men and women, okay? So in future, probably in the near future, we need to talk about a bit more gender inclusiveness. We are not talking about trans women. We are not talking about, other gender groups. We are very cisgender presentation, but we don't have much data on that, but countries have started working on that as well. And Dr. Padmini Prasad used the word sex and exercise separately, and we have got a term called sexercise, which is together. Okay, so sometimes I use the term sexercise over masturbation, because the term masturbation is a very loaded term, and when you give a different terminology, it makes convincing for some people. And all right, so Before jumping on to the actual management of female orgasmic disorder, I thought the entire audience, I don't know how many hundreds of you seeing this, this is one of my 6 equations that I normally use in other presentations. But for here, I just want to show the simple equation. It looks very simple, but it's a very powerful equation. And it makes a lot of sense when you start using it with your clients, with your patients. Now, typically when you ask a patient or a couple, how often, when you tell or make any reference to sex, by default, they are thinking of intercourse. But in my world, in my therapy, sex is not equal to intercourse. Okay. For example, if you ask an average person, okay, how often do you have sex? They may say, oh, we used to do once in a month, for example. But then if you give an explanation by what you mean by sex, saying sex is not just about intercourse, it's about everything that happens between foreplay and after play. Oh, that we do twice a week, the hugging, kissing, cuddling, everything. So this is very important to lift the pressure of intercourse and allowing and giving permission and normalizing for a person or persons to explore pleasure from sexual activity with a broader definition and not just hooked up with intercourse, right? So that's equation there. Now, all that Dr. Jindal said and part of Dr. Padmini Prasad said, if we want to put everything into one piece, this is what it is. So for any sexual dysfunction, not just for female orgasmic dysfunction disorder, but for any sexual dysfunction, this is something you can map it in your mind, okay? Now, I'm very mindful, I'm addressing to the gynecologist. So unfortunately, you guys don't have the same 60 minutes that I spend with my clients for each client. So yours have to be a rapid one. So a quick assessment, what is the issue? What can I do to the patient, okay? So if you can quickly think of why this person, okay, that's always a predisposing factor, okay? Has this person has got any medical condition, or is this person on any regular medication, or why this, is there a underlying medical condition or mental health issue or any physical health issue? Precipitating factors are why this person having this problem now, okay? This is more like the secondary, not the lifelong, the acquired one, why this person is having this problem now. Now, the third thing is what factors are maintaining the problem, okay? So without addressing the maintaining factors, we really can't move in the terms of management. So this is sort of, you can quickly have in your mind, but when a person presents with female orgasmic disorder, it's not that nothing can be done and everything is bad in that person. There might be one or two good things in that person or in the relationship that we can capitalize on, and that's what I call protective factors. Say, for example, a person may not be experiencing orgasm, but she might be having a very supportive partner. So what can we do by utilizing that protective factor to help this person? So that's something we need to keep in mind. Now, this is a case formulation I do, but I don't expect any gynecologist to do that because it's time consuming, okay? But just to give an idea how we formulate, because sexual problems in 5-10 minutes history taking, it is next to impossible to come to any conclusion because it takes about 10-15 minutes for a person to really open up, okay? So we need a thorough history, plays a major role in the management of sexual problems because we don't have any other objective tests apart from a couple of blood tests we want to run. There is no objective, any assessment per se, objective assessment to diagnose many sexual problems. Now, very quick recap from what Dr. Prasad said. I'm not going to go word by word, but the key things I've highlighted for you, okay? It's a marked delay, marked infrequency or absence. Now, the crux word here is following normal sexual excitement, okay? Now, when there is not enough sexual excitement and if there is no orgasm, then there is a difficulty in diagnosing. So it's important to remember to make sure whether there is adequate sexual excitement, because normal is a very complex word in sexuality, okay? What is normal is very varied and challenged. So probably an alternate term would be adequate sexual excitement, okay? Now, lifelong, that's how the DSM-5 goes about it. Now, DSM-5 is a tool, it's a measure, it's a process that being used in the America. Now in India, yes, we respect DSM-5. Yes, it's academically it's sound, but sometimes it doesn't necessarily apply in all jurisdictions, because there you need to have a diagnosis. In the US, you need to have, everything has to have a specific diagnosis in order to seek help. Whereas in India, the patient pays and the doctor charges. So there is no one in between. So we don't have to be overly meticulous about every single factor. And distress, okay, it's culturally variable. How a person expresses distress is variable. And also we don't have a vernacular for depression, for example. In our culture, we've been taught how to express joy, sad, sorrowness, but depression we don't have. And therefore, how depression manifests in ethnic cultures? By vague, chronic, non-cancer pain. Okay, so depression and chronic pain goes hand in hand. So it's not one size fit all, but DSM-5 is a pretty good way of framing a problem. If you don't want DSM, then I would recommend using ICD-10 and now 11, which is a lot more broader, and it can be used in many settings outside of the US. Now, ICD has got the psychological element, which is very important, which doesn't necessarily specify in the DSM. And also in ICD, we have a combined subtype where there could be partly psychological plus a medical diagnosis plus a substance use, which I think Indian setting is now picking up a lot on substance use. It's no longer, it's only a Western thing. I think a lot of substance use is now becoming prevalent, especially chemsex and all those things are coming up. So it's important to ask about substance use, provided the demographic of the population you're serving. Now, what is the main challenge in the management of FOD? Okay. Now, there are so many challenges. Right from the definition of orgasm is a challenge, but one of the key challenge is this. FOD almost always presents with other difficulties. I'm sure Dr. Jindal would agree with me and Dr. Prasad would agree. If anyone who has treated FOD, it is not always, I have desire, no issues. I have arousal, no issues. I have nothing issues. Just I'm not getting orgasm. It's not always common. Okay, there's always something or the other. Okay, whether there is a high comorbidity with arousal, or there could be an issue with lubrication, or sometimes there's an issue with desire, and sometimes it's the genitopelvic pain penetrative disorder, which is now the appropriate terminology for dyspareunia and vaginismus together. So there is always other problems which needs to be addressed as well, part of the treatment. Now, this is nothing specific to FOD, but an overarching principle. This is according to the European Society of Sexual Medicine. So we need to take a person-centered approach. It's not like one size fits all, and we have to take a person-centered approach and being, say, for example, being very mindful of not introducing vibrators, just a mention of it, and then they go Google it, somehow find a vibrator, you start using it and not able to see any success with that. Now, the problem with that is they don't know that female orgasmic disorder is a very complex condition and they need to be taken a lot of history around it. They don't know anything. So when they read something about vibrator, they buy it and then they use it, it doesn't work. What happens to them is they start believing that their problem is very big and deep. Even a medical doctor cannot fix it. So I am a failure. So that's why it's important to take a person-centered approach. I know it's a big ask for very busy practitioners, gynecologists. I heard from Dr. Datta saying we could hardly spend 5 to 10 minutes. But in that case, we can have a different strategy. But if you want to do justice, especially with orgasm, topics like orgasm, you need to take a person-centered approach and also mapping sexual problems. Is this a concern or a difficulty, dysfunction, or a disorder? What is it? Okay, not everyone who comes to us thinking they have something abnormal actually have something abnormal. They don't know what is normal. Therefore, they think they have something abnormal. So making it very clear whether it is a concern or a disorder, that's very important. And also using some evidence-based diagnostic and treatment planning, like exactly what Dr. Prasad and Dr. Jindal said, but we'll also look into some further evidence for these. And also having some unified management approach, okay? And gynecologists could adapt this and see how much they can go into the algorithm and where they can start referring the patients to someone else. Now, person-centered approach. Now, I'm not going to go in great detail here, but what we need to understand is we are talking about function, then we are talking about satisfaction, and then we are talking about dysfunction, which is the actual confirmatory diagnosis. But a lot of time, I find that if we take a good history about function and the satisfaction, even though they don't have a lot of distress about it, then we can still work as a diagnosis, a descriptive diagnosis, rather than having a definitive diagnosis. Now, we need to be very mindful of not giving a definitive diagnosis, especially when we haven't taken a full thorough history, because for a person, it gets stuck on their forehead and they carry that as a label, okay? Say, for example, you can treat a person as difficulty with erection as opposed to giving him a label erectile dysfunction, okay, which is a definitive diagnosis. So in women with FOD, before jumping on to say you have female orgasmic disorder, we can say, look, you're having difficulties. Let's work on how we can improve your orgasmic experience, okay? So that softens the tone of it. Now, this is the unified approach by the ICSM, so which is very simple 5-step process. So it starts with the evaluation, with the history taking. Now, the European way, the Indian way that we adapted is you start with history, you come up with a list of clinical questions, and then you do investigations to answer those clinical questions, and then you move on with your treatment. Whereas the American way is very much you start with investigations, okay? And then you retrospectively work, because especially in a country where there is medical legal cases are so high, they eventually have to do investigations. But in my opinion, doing investigations without a thorough history doesn't yield much to the patient or to the treating doctor. So therefore, a good history and then asking for examination if and when needed, and then going with investigations, treatment, and evaluation, okay? So just because orgasm is fixed doesn't mean the couple is going to have a happy sex life, or let alone the couple, even that person might not still be happy about their overall sexual experience. So orgasm is a main thing. It's one among overall sexual experience. Now, if at all anyone is super keen in treating female orgasmic disorder and want to know the best evidence with graded evidence, I would strongly recommend going into this article, and it is an open access article you can freely download, and it's fantastically written, and we are going to use this as an article to refer to. Now, this is very much in the assessment, but what Dr. Jindal said, my presentation could be very simple by saying, okay, you address everything Dr. Jindal said, treatment for FOD is over, because it's very much addressing each one of the risk factors. Now, psychosocial factors, low educational level. Now, what can we do about low education level? We cannot go into the educational level of each and every client. But what we can do is we can address the health literacy. Now, one thing we need to understand here is knowledge and health literacy are not the same. Knowledge is you have the raw information. Now, there's a lot of sources today that gives knowledge about a particular condition. But what we are lacking is health literacy. Health literacy is the ability to use that knowledge in order to make informed decision. Now, that is where a gynecologist's role can be very helpful to address the educational aspect, the knowledge and literacy aspect of it. Now, sexual inexperience, there are a lot of sexually naive people who don't know anything. In a way, those who don't know anything, if a client comes to me and knows nothing about sex, in fact, I'm happy. So that it's like a clean white page. I can start writing the script together. I'm not writing my script. I'm writing the person's script with my guidance. But that is very, very rare. People who come to me have already got a script that they have taken from pornography, they have taken from internet, they have heard from their friends. Somehow when it comes to sex, they somehow believe whatever the friend says has to be true. So that script has to be erased. Whatever that is faulty, it has to be erased and rewritten. So it looks a bit messy. Now, cognitive factors. There are a lot of cognitive factors. Let me pick on one, body image. Now, a lot of women now having that they have to be in a certain way. And once again, the media influence is very high. And you know how much hair I should have in the body, whether I should shave it, whether I should do a Brazilian, whether I'm looking good, whether I'm smelling bad, whether my body odor. There are a lot of factors that goes underneath body image, okay? And especially when the partner is very critic of the body image, or even women who are concerned about their breast size, women who are concerned about their labia sizes, and women who are concerned about their stretch marks, okay? So there are a lot of issues that goes with body image, which can be a shutdown factor when it comes to arousal. Now, likewise, relationship factors. There are a lot of relationship factors, but one of the key one is communication. Okay. Now, I'll always be taken by surprise when I have couple come for counseling, when that is the first time they're able to express their true self to the other person. Okay. So communication, when it comes to sex, it's a big issue. Okay, so definitely communication has to be improved. Now, once again, childhood maltreatment, developmentally, how that has affected. And we should also take into consideration that when we teach girls, okay, so we tend to tell them, don't touch there, it is a dirty organ. For boys, somehow they have to touch it in order to go wee. Whereas with girls, there is a double standard, don't touch there. It is dirty, it's a dirty organ. But in fact, it is not a dirty organ. It is a beautiful organ. It is part of your body. Something dirty comes out. In fact, urine is not that dirty secretion of the body. It's one of the sterile, provided there's no infection. But we somehow teach it's dirty. And a lot of girls have that idea in their mind that they're not supposed to touch down there. which is something has got a major impact when they grow up into an adulthood. So that's something we need to teach them to become more friendly between the mind and the body of their own. And a lot of women haven't even visualized their own vulva. Okay, you'll be taken by surprise how many women, young women or even older women, haven't ever once visualized their vulva. So that's why in Australia, in the family planning, they used to give a mirror to put in and actually look at it, to look how the body part actually looks like. And medical history and medications, Dr. Jindal has already addressed. Now, treatment-specific standard operating procedures. Now, partner can make or break situation, provided the person with FOD has got a partner. It's important to involve the partner at the right time, at the right level, and address any sexual problems in the partner. Okay. Now, somebody said premature ejaculation is a problem. Yes, it is a problem, but it is not so much of a problem if the female partner in a heterosexual context, if the female partner had experienced the orgasm, and then if the male ejaculates in whatever time he ejaculates, then it's not so much of a problem. And in fact, women, once they have experienced orgasm, they really don't care how long the man stays. They'll be happy if they finish quickly. But it is not about premature ejaculation per se, but when it happens. Men think sex starts when they get erection and sex finishes when they ejaculate, and job done, they walk away. Now that is a problem. Okay, so we need to understand how the partner dynamic works. Now, the implicit approach, now this is a very, very important point, especially for gynecologists who are time poor. Okay. Now, I have published an article recently, not recently, last year, especially talking about management of sexual dysfunctions, especially from a general practitioner perspective, which can very well be adapted for gynecologists. Now, that article is also freely available. Now, implicit stands for permission, limited information, specific suggestions, and intensive therapy. Now, the last two, forget about gynecologists. It's not practical for you guys to do. But permission and education are definitely something you can do. Now, the best a patient able to disclose and tell what they're experiencing and being heard by you, gynecologist, without any judgment and with empathy, no sympathy, but with empathy, opens up the trust that, yes, I can talk to my doctor, is therapeutic in itself. You don't have to do anything, but just listening with empathy and without looking at your clock, being honest to hear about their story is therapeutic in itself. And that's a big difference. Okay. So that's a first level of giving permission to talk about how they feel about their own sexuality. Okay. Now, limited information. Now, all that you hear from this today's webinar, you can use this passing on to your patients as limited information. Okay. What are all the myths? Doc, I have to have orgasm at the same time when my husband has, or when the male partner has orgasm. Therefore, the two orgasms have to happen at the same time. And that's when the baby is formed, it will be very healthy and brilliant, intelligent baby. That's not necessarily true. Okay. So there are a lot of myths and misunderstandings when it comes to orgasm. Okay. Now the penis has to go deep inside, only then. So there are a lot of myths like that. And also, if the penis size and orgasm, once again, that's a very interesting area. And if clitoral glands is the most sensitive, it really doesn't matter how long the penis is, as long as if it is thick enough to give the enough pressure. But even without that, let's not talk just about vaginal orgasm versus clitoral orgasm. Even with vaginal orgasm, what is getting that orgasm is the clitoris. So Why can't we stimulate the clitoris, not necessarily relying on the penis? Okay, so thankfully a finger has got a bone and it's never going to lose erection. Okay, so it's always going to be stay up. And also there are other parts in the body that can be used to stimulate the clitoris. Okay, so there are some limited information you can pass on. Now, specific suggestions, if you're confident, and I even told Dr. Datta in the beginning, all gynecologists are sexologists because reproduction is part of sexuality. Therefore, gynecologists are sexologists. And you don't have to be an expert in sexology in order to pass on some specific suggestions to your patients about sex. And so does for orgasm. Okay. And it's okay not to experience orgasm and rather chasing to find an orgasm and not being able to experience the present and pleasant moment of the whole sexual experience is something you can pass it on as a specific suggestion, and beautifully said by Dr. Prasad about how chasing for orgasm actually kills the thrill. Intense therapy, which is not meant for general practitioners or gynecologists. This is where people like who are trained in psychotherapy, like myself, who spend a lot of time, and we work with individual client and couple. Okay. Now, management of FOD, hormonal testosterone 300 microgram has reduction in FOD symptoms, plus it improves the orgasmic experience. We need further research on PD5 inhibitors. We still don't have very strong evidence, and we also don't have much recommendation for nutritional supplements, although there's a lot in the market selling certain nutrition supplement will boost the orgasmic experience. As per the standard operating procedure, based on graded evidence, it is still not being recommended. Okay, that not being recommended doesn't mean there is no use. It just not have enough evidence data to prove that. Now, those who have medication-induced FOD, like Dr. Jindal said, so if there is a medication-related induced FOD, it's important not to mention to the patient that, bang, this medication is causing you this problem. And if the patient only hears what they want to hear and goes stop taking that medication, say example, antidepressants without proper tapering, it can end up in huge problems. So it's important to work with individual patients. Now, the rule of thumb is if a symptom happens more than a month of giving the full dose of a medication, we need to be really mindful whether this is medication induced or not. Okay. So it is very easy to point everything to a medication saying, oh, it is because of this medication you're having this. We need to be very careful. And there are some techniques what we can do, reduce the dosage, reduce the frequency, or give some drug holiday. And also we need more evidence to support giving PD5 inhibitors to counteract the effect of SSRI, because what we end up is prescribing cascade, which we don't want to see. Now let's come to the crux of non-pharmacological interventions. Now, I heard Dr. Jindal saying masturbation is not well regarded. I agree to a certain extent, because a lot of Indian women, masturbation, they don't know anything about it. They don't even know that women can masturbate, and they heard a lot of negative information about masturbation. Although I'm seeing a big shift in the trend now, where I have even a couple where the man hasn't masturbated, but the girl has. So there's a mixed bag, and there's a shift happening. Now, directed masturbation is not just doing bang, bang, bang. It's about a very structured way of doing a masturbation. We call it mindful masturbation, which has got the strong evidence and recommendation from the SOP. Now, sensate focus, it's once again, it's part of sex therapy where we have graded exposure. The rule of thumb is not to have intercourse at all. So it will be very sensual and then become more sexual. And sensate focus can be a great adjunct to directed masturbation. Now, reducing distraction and spectating. I don't know how many of you know spectating. Spectating is how a woman thinks and feels, putting herself in the other person's shoe. Okay, what will my partner think of my body? What will my partner smell of my body? What will my partner think if I don't express orgasm? So they are thinking too much about themselves by putting themselves in the other person's shoes, which is not a good recipe. And combination therapy, where directed masturbation with sensate focus, and then we have other techniques like role play. Role play is you intentionally make the women lose control, okay? Because these are women who have excessive control of themselves and they fear losing control, okay? Where in the role play, we on purpose, we ask them to lose control so that they can relax themselves, okay? And feeling that high control could be an underlying sense of insecurity, or we need to take thorough history of what was the previous sexual experience. And there are some other adjuncts that we can use. Now, coital alignment. Now, you can suggest whichever position you want, but the idea is to maximize the glans clitoral stimulation. Now, this is an image, and this is a position where the male aligns his pelvis along the pubic bone of a woman, and where he is only allowed to go up and down rather doing the side push and pull. Okay, so this vertical rubbing gives the glans clitoral the enough stimulation for orgasm experience. Remember, stimulating the glans clitoris, you're also trying to stimulate the entire clitoral complex and the anterior vaginal wall complex, the erogenous zone. Once again, may not work for everyone, but it's worth giving it a go, right? Now, orgasmic difficulty, we need to understand there are emotionally aroused but not physically aroused. But then there are women who are physically aroused but not emotionally aroused. Okay, they may not be looking, the thing is, all men are ready for sex at any time, and they don't need emotional intimacy. They are just about physical pleasure. Whereas women, they always need an emotional intimacy. They always want that emotional connection in order to be sexually happy. Now, that model does not hold true hereafter. Not all men always want just sex. Not all women always need emotional intimacy to be sexually aroused. So there are exceptions to both the groups, and we need to take that into consideration. And well, how to manage arousal difficulties. So once again, these are all different techniques. I'm being very mindful of the time. Now, it's important to understand that it might take a longer time for a woman to get aroused, and that we need to take into consideration and make the male partner be aware of that. Okay. Now, achieving orgasm. Once again, I said becoming friends, the mind and the body. The body, the main sex organ. I always ask my clients, what's the main sex organ? It's the brain, not the vagina, not the penis, not the clitoris. It's the brain is the main sex organ. And how to connect the brain, the body with the genitals, you have to become friends. Okay, and that's a very important one. And there are other techniques that we can use, and especially arousal enhancements. We can use vibrators like Dr. Prasad told. We can use different techniques, simple as finger, because it's not always easy to get a medical aid or vibrator easily. There are some logistic difficulties in getting them, but fingers, okay, what can we do with the fingers, provided the nails are cut, provided there is an agreement to sexually stimulate that way. Okay. Now, there are different orgasmic difficulty presentations, and the management differs depending on the presentation. Some women have with partner, but not on intercourse. Okay. They have difficulty with orgasm with partner, but when the partner stimulates with finger, no issues. But on intercourse, they may not be able to because the pressure may not be adequate or appropriate. Some women can have orgasm on their own, but not with a partner. There could be a relationship issues, something happening in between them. And some women have never achieved an orgasm. Okay, to be very simplistic, orgasm is nothing but a reflex. Okay, but we need a good 20 minutes of stimulation to reach orgasm. Okay, so that's very important. There are some differences in the timing of that needs. Okay, but once again, all this data is based on Caucasian women. Okay, if you really want to know what is the situation for Indian setting, we need more scientific data in the Indian setting. Okay, now once again, the prevalence was so high among Asian women. That's because the definition that is being used to assess and quantify is a Western-based definition. So we need to take into consideration whether the definition is suitable and culturally appropriate and customized for the Asian setting. Okay, we need to be mindful of that. Now, these are some techniques that you can tell. There's no need for shyness and better communication. You can show what you want, education, and different positions that I showed before, and vibrator. It's giving permission to use vibrator could be a big thing when it comes from a gynecologist. Okay. Now, in summary, so the non-pharmacological is CBT, especially if they're having a lot of faulty thinking pattern. CBT plays a big role. Directed masturbation, anxiety reducing techniques, systemic desensitization. The evidence is not so great for orgasmic, but for anxiety, it is very good. And then we can talk about other techniques. Pharmacological, testosterone, PD5, if and so. Okay, and medical devices are always a good adjunct. The case. Okay, Dr. Janav, are we okay with the timing to go with one quick case?
Yes, no, it's perfect, no problem.
All right, so Anju and Vivek. Anju is 24 and Vivek is 25. Okay, so imagine them. They are the modern generation, young, very adventurous, they live together. Marriage is not a compulsory. They had sex before. So they sort of, the modern day sort of generation. Sorry, so I've changed the name here, sorry. So Anju, so presence with this. I suffer from anorgasmia, okay? Now, where she got that, she self-diagnosed herself from Google, okay? She put in something, she thought, I have anorgasmia. The problem is urgent. Dr. Datta, you need to solve this problem immediately for me. I have tried everything, nothing is working for me, okay? Now, I can't get myself to orgasm. This is causing a conflict in my relationship. And then they actually had a short breakup and now they are back together. But when they are back together, Anju is very keen to actually fix this because she's feeling very insecure, okay? And she thinks that she's failing on her role to express that she enjoys sex of her boyfriend, okay? So she wanting to please him because she thinks that he feels disappointed. Even though she's enjoying sex, she feels he's disappointed by not seeing her come to orgasm. So it's a very complex thinking pattern. What shall we do here? Dr. Prasad, Dr. Jindal, the panel, Dr. Datta, what would you do? Dr. Datta, come on.
Sir, counseling part is definitely very, very important because in the starting you have mentioned that she was self-diagnosed from the Google. So I think this is because the main problem with all of us, and especially we Indians, or I think all of us have, that whenever you have some doubt, we just Google it. And Google have all the unfiltered information, all the bakwas, all the rubbish information. So they take it that and they have read it and they have that. So I think
not just Indians, Dr. Datta. That's everywhere. That's global pandemic.
okay.
Yeah.
So I think, sir, counseling part is very, very important in this case. Yeah, that's the thing, sir.
Okay, that's fine. What would you do? You're the gynecologist. Anju has come to you today.
A proper history taking and
Yeah.
into the details and depth of the coital history. Where is the
Yeah.
problem? Whether
Okay.
they're having.
Okay, ma'am.
Yeah.
I am Anju. Ask me the questions. We are doing practical. We are doing a real time here. We don't want abstract answers. I am Anju. I am Vivek. Whatever the question, ask me.
Yeah. So these are youngsters and looks healthy people. And
Mhm.
first thing is about the interpersonal relationship and coital history and what are their expectations and the realistic expectations we have to look into. And
Okay, how would you ask me, ma'am? You can ask me the same question. Imagine I am Anju, I am Vivek in front of you.
So how often they are together, they are in relationship and how much they trust each other. Interpersonal relationship is how do you trust how much friendship you have, how much trust you have.
I used to trust him before, but because of the breakup, I'm not trusting him anymore because if I'm not going to fix my orgasm, Vivek is going to leave me.
Yes. And the other thing is about the details. Can you just tell me whether you have got a desire and about the privacy and where exactly you meet and do you have any other tensions or anxieties about the relationship? Or if you say, because she also says, I am enjoying it, but
Yeah,
he thinks
that's right.
she is not
That's
enjoying.
right. That's right.
So,
No.
yes.
When he penetrates, when he does oral sex for me, when he does oral for me, I enjoy it. It's just that I can't experience this bloody thing called orgasm.
Yeah, what she thinks maybe that she may be experiencing orgasm, but the thinking that because she is looking into the Google and whatever they're in an exaggerated way, what they are describing in Google or in the media. So
That's
that
right.
she may be relating to that.
No, but I have never experienced that tension, that full tension release. I've never experienced that at all.
Yes. So in that case, with even after a full proper stimulation and with a proper foreplay, and if she is still unable to reach orgasm, then we'll have to go into all this about the sexuality education, how much she has to look into
But
stimulate herself and what level of arousal she
that's right.
gets in
So
a person. Yes.
that's right. Dr. Jadhav, do you want to ask me one or two questions? Very specific questions. Or Dr. Jindal? See, in situations like this, it's important to ask about, in a dyadic sexual relationship, whatever Anju is experiencing in the relational context, there is influence of Vivek. It's important to ask history about Anju's masturbatory behavior.
Exactly.
Has she ever experienced orgasm when she masturbates? Because masturbation is not just an act. Masturbation plays a significant role in how a person sexually develops and how the person has related their mind to the genitalia. So, and that's what my PhD was on. So in a situation like this, if you can take history about Anju's masturbatory and whether she was able to experience orgasm by masturbation or not, will give some very good indication. Is it something that Vivek does is not meeting the requirement? Could be a coital position, could be the thickness. Remember, in penis size, it's not always about long penis, it's also about a thicker penis, because a thicker penis can give more pressure, because long penis, a thin, long penis doesn't make a big difference. But a slightly shorter but a thicker penis can give more pressure. And remember, the A spot, O spot, all of those spots works on pressure mechanics. Okay, So that's why it's important to take a good history about masturbation. All right. Anyone else would like to chip in? Any other question?
In the masturbatory history, we would
Yeah,
like to
Dr.
ask, have you felt during masturbation any kind of something or any kind of a feeling or sensation which you could link with orgasm? And is it something which you have not experienced in the sexual act which you have had? So it's actually a question of correlating the masturbatory orgasm or the clitoral stimulation with the stimulation which she's getting out of the intercourse.
Okay, but sometimes we are making an assumption here that masturbation is clitoral stimulation. Some women do actually do the full penetrative intercourse and may not be even touching the clitoris. So once again, a very good point, how she has programmed herself to become orgasmic, if at all she had experienced orgasm. But if she had this idea that she cannot touch herself, if she has never masturbated, then that's altogether a different story. Yeah?
Correct.
Anyone else? Dr. Datta? You can ask me one question. You can treat me as Anju or Vivek. You can ask me.
Vivek, sorry. Vivek, how much time do you normally take during intercourse?
Intercourse, about 25 minutes.
So you discharge after 25 minutes normally?
I fed up because I can't see her coming to orgasm and I lose interest afterwards and then I take it out, masturbate.
Okay, so in 25 minutes, you cannot ejaculate and you go on to 25 minutes only because you want to give an orgasm to your wife?
Correct. My girlfriend, sorry.
Sorry, your girlfriend. That's the reason you stay for 25 minutes.
Yes,
so,
yes.
So now the next question is, in case your girlfriend had an orgasm in 5 to 10 minutes, would you have ejaculated?
Of course, yes. Purposefully, I'm holding it back because I want to give her the chance to feel orgasm like what we used to watch in movies, but somehow I'm not able to see that in her. Although, it is disappointing. I really love her.
Have you been able to give her, does she feel happy when you give her oral sex or you stimulate her?
No, I haven't discussed about that. I feel a bit embarrassed to ask that. Is it something okay to ask, Dr. Jindal, to Anju?
Of course you could ask. Have you ever used your, I would say, fingers to make her happy?
I have once. She started her body starts a bit shaking, but I don't know whether that is the beginning of an orgasm. But when I put my finger, she tends to enjoy that. But we haven't really explored that.
So don't you think it's a time to explore it?
Yeah, I think so. Now that you have asked me, I can talk to her.
So after talking to her, don't you think you'd like to explore that part so that ultimately she may be able to understand what exactly she wants from you?
Yeah, definitely, Dr. Jindal. I'll do that.
One thing is, why should he have so much pressure to have orgasm? So they told orgasm is not necessary for no sexual happiness or anything. If the wife is happy, he also should feel happy. That why should he put pressure on himself?
That's right. That's where. That's
performance
exactly where.
anxiety. Performance anxiety is the one which is causing the problem.
Performance anxiety, but this is where the CBT comes into play. The sense of should. I should orgasm.
Yeah, he's putting pressure on himself.
That's right. And then if you look at, we call this as thought fusion. What if I don't experience orgasm? What if he's not happy with me? What if he leaves me? So you start linking questions after questions. It becomes thought fusion action. Okay. So yeah, that's a very good point, Dr. Prasad.
And this pressurization is more in an unmarried, so insecure relationships. Because after marriage, even if there is some disturbances, they just get used to each other and somehow correct it and then they move on. But this pressure is, I have seen in youngsters. So when they have this premarital relationship or temporary friendship relationship, I have seen this pressurization. Any amount you explain to them, tell them, they are not convinced. No, I am not enjoying. No, I am not
That's
happy.
right.
My wife is
That's
not.
right.
And sometimes
That's
it
right.
really becomes very difficult for
Very
us to
difficult.
convince.
And that's
Yes.
right. Once again, at least in this situation, they still have an option to go seek a different partner. Whereas in a married, and if they think divorce is something bad, they're stuck for life. And they somehow think having a child will fix everything, and they'll somehow get a child, and still they feel a big vacuum in their sex life. So it's a different situations. Yeah. So I'm being very mindful of the time. Sorry, Dr. Jadhav, I've stepped over a few minutes.
No, it's okay. No issue. We love this.
Yeah. Anyone else would like to chip in? All right. If that's the case, I would like to say a big thank you to everyone, and it's been a pleasure to be part of this panel.
October, there is one question. Dr. Vijay, can you answer that if FOD can be chronic?
Yeah.
If FOD can be chronic?
Maybe. There is no terminology for chronic. It's either lifelong or acquired. But yes, it could be for a long time. If you're using chronic in that sense, yeah, it could be for a long time.
And I think there's a lot of questions in the chat box and previously also, but I think we have covered all the questions by you, all the faculties. So, sir, it is I think we already exceeded the time, sir. Neeraj, sir.
Yes,
so very shortly, we can ask from Padmini ma'am and Sunil, sir, just a few last line terms or some very interesting cases in very shortly. Padmini ma'am, first from you.
Yeah, so this pressurization to have orgasm is a fair recent on the origin, I can say, because so many times the women who come there, so some people do not know what is orgasm. Some women are very happy just being with the husband, and that is their sexual satisfaction, the closeness and the touch and the love, intimacy. And some women who really are discussing about it, or some other people putting in their mind that you have to have sex in this particular way. So the pressurization starts, and then of course, for orgasm, definitely it gives pleasure to them. And if the couple is able to explore it and understand it and help each other to reach orgasm, that is really a wonderful thing for a woman's liberation and a freedom or a right or whatever you can call. It is woman's right to have a pleasurable sex free of coercion or pressure or anything like that.
Beautifully said, Dr. Padmini. In fact, to have mutual sexual initiation, to have a good sexual technique together, and for both to work emotionally beautifully, and approaching sex openly and appreciating each other is probably the story of a good, happy sexual life.
Thank you.
And,
wow.
and from my side, sex is not equal to intercourse.
Great.
That's my closing comment. And Dr. Datta,
yes,
I have included a journal article. Can you see it in the chat box?
Yes, sir.
That's so that will be available for all audience. And I'm also adding one more journal article that I published.
Can you, Dr. Vijay, can you send it in my mail, because I will send it along with the certificate. I will send both the link.
Yes. I'm also. Yeah, and
I can send that.
Yeah, I'm sending my journal article on implicit model as well. So 2 articles, I will send it as email as well. Yeah.
Thank you so much.
We will share it with everyone.
Yeah.
Thank you, everyone.
Thank you so much. And
thank you, Dr.
It's such a pleasure. And thank you, Dr. Vijay, because at this moment, I think you must have passed midnight.
That's right. I started yesterday. I'm finishing it today.
Thank you so much.
Dr. Prasad.
We
Thank
can
you.
have a vote of thanks. Apurva.
Yeah. Thank you so much. First of all, the Foxy President, our dynamic Dr. Alpesh Gandhi sir, our Vice President in charge, Ragini Agarwal ma'am, our Secretary General, Dr. Jaideep Tang sir, for always blessing us, and definitely none other than but Neeraj Jadhav sir for his dynamic and for his vision to make this, a sexual education to door of every and each and every gynecologist of India and outside. And definitely, last but not the least, the faculties for today. Vijay sir, thank you so much to spare your time away from from Australia. Then Padmini ma'am, Sunil Jindal sir, for giving your precious and spare time for us. And last but not the least, our team, our supportive partner, the entire group, Lai Desai is always with us, and thank you so much to the entire. Thank you to everyone.
Thank you, ICOG, Dr. Mandakini Meg and Dr. Parag Biniwale for granting us one ICOG credit point for this
Okay,
session.
thank you.
Thank you, Mr. Satpathy of
All
the
good
Vikas
night.
Pharma.
Good night. Good night. Take care.
Thank you, everyone. Good night.
Thank you.